Thank you for joining our webinar, Self-Management to Stay Well with Bipolar Disorder. I am honored to introduce our presenter today, Professor Greg Murray. Professor Greg Murray has an international reputation for clinical psychology research, being ranked in the top 1% of researchers worldwide in the field of bipolar disorders, circadian rhythms, personality, and affect. He has published more than 200 articles, chapters, and books on the conceptualization, etiology, and treatment of mood disorders. After a first career in music, he took out his PhD from University of Melbourne in 2001 and has been a full professor at Swinburne since 2011. Thank you so much for joining us today, Greg. You're welcome to get started on your presentation whenever you're ready.
Thank you very much, and thanks for this opportunity to present for the International Bipolar Foundation, who have really helped us a lot in the work we've been doing on bipolar disorder over the years. And welcome everyone to today's seminar. It's I love doing these webinars, knowing that people from all around the world potentially are joining us, which is very exciting. And it's also particularly exciting because today is Max Weinberg's birthday. Right? I know we're all excited about that. Does anyone know who Max Weinberg is? I reckon some of you will. Max Weinberg is Bruce Springsteen's drummer. My first career was as a drummer, as you can see from the gear in my room. And Max Weinberg is one of my heroes. So he turns 70 today. So I'm sure we'll just deep in our hearts be sending him birthday wishes. So welcome. The only sort of downside to these webinars is it's harder to make them interactive. Obviously, it would be great fun if we were all in the same room, because really the aim of today's talk is to get you thinking about what works for you, and that's actually probably better done if we were face to face, because you could say things and we could discuss things. So it's going to be a bit more me talking than it would ideally be the case, right? But you can put questions in the Q&A or the chat, and if we don't get to answer all those questions, if your question doesn't get answered, that's my email address there, and I'm very happy for you to just flick me an email with a question or a follow-up. Okay, so yeah, if things come to your mind, or not even questions. I mean, I'm going to be talking for about 40 minutes or so on self-management to stay well with bipolar disorder, but obviously you may have ideas for me, things that you say, well, that wouldn't work in my case, or I tried that and what I found was this, and I would love to hear that as well, right? So this talk improves every time I give it, because people give me feedback about what their lived experience is like. So as I say, what are we talking about today? We got very interested a while ago with my colleagues in Canada. We got very interested in this question of what works for people with bipolar disorder. And of course, there's the scientific literature on medications and randomized controlled trials. There's now also a scientific literature on psychological treatments for bipolar disorder, again, with randomized controlled trials. And as I hope many of you already know, the best practice treatment for bipolar disorder is a combination of medication and psychological treatment. So that's what we get from the scientific literature. We know that. But we started to think, hang on, there must be other ways of getting into the nitty-gritty of what works for people with bipolar disorder. So in fact, a colleague of mine in Canada, Melinda Suto, who's a social worker, had the idea of putting out a call for people who self-described as managing their bipolar disorder well, and we got them in and interviewed them and asked them, well, what do you do to make sure your bipolar disorder is well managed? And essentially this talk is the result of that piece of work that we did. But I just want to highlight that that piece of work, what we found, which I'm going to introduce you to today, pretty much parallels another study which was done coincidentally in Australia. I wasn't involved with it, but a gang in Sydney in Australia did a very similar study to one that we did in Canada. And the themes emerging in those two studies were pretty much identical. So what I'm presenting to you today emerged from one piece of work, but it's kind of been validated by comparing it to other things that have been done. So out of the work we did, where we spoke to these people who manage their bipolar disorder well, we found 7 major themes, and that's what I'm going to lead you through today. Step 1 in terms of self-management for bipolar disorder seems to be that it's really important that you know a lot about the disorder, and ideally that people around you also know a lot about the disorder. I'm talking about things like, for example, that bipolar disorder is a waxing and waning condition where people are sometimes quite well or perfectly well, and at other times become potentially quite unwell. And even between those times when people are, significantly unwell, there might be waxing and waning of mood symptoms, sleep problems, etc. So the reason that's an important feature of bipolar disorder is it makes it like a chronic condition, a bit like diabetes or something like that. And the general public may not be used to thinking about mental health problems in that way, right? It can be surprising to the general public who maybe have a model of mental health problems in their head, which is about much more sort of acute mental health problems. Someone has a stressful experience and they become depressed, for example. It's a one-off, it's an acute thing. That's not the case with bipolar disorder, and we may firstly need to appreciate that ourselves as someone with bipolar disorder. That's something that you might need to come to recognize and accept about what's going on with the condition. But you also may need to communicate to other people in your social network so they are expert on that feature of what we call the course of the disorder, or the average course, because everyone's different. And then other key features that we need people to understand is the importance of medication and the importance of staying on prescribed medication. And of course, we'll talk about this in a minute as well, that involves having open and frank discussions with whoever is prescribing the medication. So yeah, we know from quite a lot of work that people with bipolar disorder often have very mixed feelings about the medication. And at particular times, they might think, well, I want to be off it. And really the key take-home message about being expert on bipolar disorder is, if you're having those sort of thoughts about coming off your medication, really what needs to happen next is you go to the prescriber and talk to them about it, right? There are really important aspects of managing medication which require that sort of expert input about chemical balances, etc. And that really should be handled as a dialogue with your clinician. Oh, just looking at the slides, I just want to highlight something. So all 7 of these slides will have the same structure. Notice that the dot points there are actually questions, and so they're not statements. So I really encourage you to have a think about these things. And obviously, if we were face to face, I'd be saying, what's your answer to these questions? But they're meant to sort of stimulate you to think about, well, where did I get my knowledge about bipolar disorder? Have I, done as much research as I could? Are some sources of information much more useful than others? Are there, and then that second point there, what's the most important thing you think people need to know if they have just been diagnosed with bipolar disorder? So it's kind of like a summation of all your knowledge of bipolar disorder. If you had the chance to speak to someone who was recently diagnosed, how would you encapsulate all that knowledge? What's the single most important thing? And similarly, what's really important for people around you to understand about bipolar disorder? I think that's a really important question for people to reflect on, and make sure in your own mind that once you've worked out what that is, that we're talking there about the unpredictability of it. For example, sometimes people with bipolar disorder say, I really need people around me to understand that, one of the most challenging aspects of bipolar disorder is the unpredictability of it. And therefore, I want people around me to understand that sometimes I might not follow through on something. And we often hear from people with bipolar disorder that one of the most challenging things about the disorder is they can often end up feeling, quite guilty or embarrassed about how they've failed to sort of hold up their end of some sort of relationship commitment, right? As the disorder has got in the way. And that might be something that you really want people to know about bipolar disorder, that you're conscious of how it can affect relationships sometimes, yeah? And then the other thing that I think is really important for people to be clear on is about the strengths that are associated with bipolar disorder. And you've probably heard of these things like creativity, which is definitely measurably more common in bipolar disorder populations than in the general public. But in terms of sort of measurable sort of achievements in terms of creativity, but it's also, creativity is also often like a temperament that we see in people with bipolar disorder. It's kind of part of their way of being in the world, and it's something which is therefore a strength that we need people to understand and embrace as an important part of staying well. It's one of the things that we really think is important is, staying well is not just about preventing symptoms. It's also, of course, following things and engaging things with things that are meaningful to you, that really give your life meaning and help you connect to other people. And for a lot of people with bipolar disorder, that's something in the domain of creativity. So these are the sorts of things that people with bipolar disorder who manage their condition well tell us are really important around this topic of being knowledgeable. But I suppose that, the core take-home message from me here is you can't afford not to be expert on bipolar disorder. And because bipolar disorder is managed, through psychiatry, doctors, psychologists, in the mental health system, it's quite important that you get your head around what that system thinks about bipolar disorder. Now, that's not the be all and end all of what bipolar disorder is, but it is a very important thing that you will be interacting with a lot. So you'll want to know what, bipolar 1 is, what bipolar 2 is, what differentiates hypomania from mania. And I'm sure many people on this call will understand that. But if you want to engage with your psychiatrist, your doctor, your psychologist, and speak their language, which will, of course, would be useful for you, then it's really useful to learn their terminology. So let's look at the next point. The other thing that stands out both in our research with people who say they're coping well with their bipolar disorder, but this finding also comes out very, very clearly in the research into psychological treatments for bipolar disorder. There are 4 recognized evidence-based psychological treatments for bipolar disorder. I'll just quickly name them. One is called psychoeducation. One is cognitive behavior therapy, CBT. One is interpersonal and social rhythm therapy. And the other one is family-focused therapy. All four of those have a strong evidence-based as adjunctive to medication. So combined with medication, any one of those four is useful for people with bipolar disorder. But my point now is that all four of them, all four of those psychological interventions emphasize this feature, that people with bipolar disorder really, because of the nature of the condition, which comes and goes and crises can sometimes arise, people with bipolar disorder really must have, it's really useful for them to have, a plan, which includes keeping an eye out for early signs of relapse and a plan for what they're going to do should crises occur. And of course, by crises, I'm thinking of acute events like, for example, starting to become manic, or starting, for example, to have very significant suicidal thinking. These are things that are time sensitive, aren't they? Things can change very quickly around those sort of phenomena like suicidal thoughts and becoming manic. These are time sensitive, so we call them crises. But of course, there are other changes, like, for example, starting to slide into depression, which is perhaps not as time sensitive, but equally important to do something about, right? And so what we know is that having a plan which involves developing your knowledge of your own, what we might call a relapse signature. What do you start to notice as you're heading into depression? What do you start to notice as you're heading into hypomania? And obviously people get better at noticing those things over time, right? The more episodes you've had, the more expert you are on recognizing the pattern, yeah? And a lot of people actually find that it's not the obvious things that, you know, they say in the textbooks that constitute the early warning signs. So for example, I'll give you a couple of examples from people that I've worked with. One of my clients realized after quite a number of depressive episodes, he said to me, "Oh, I now know what the earliest warning sign is of me sliding into depression." Because you can just, on that, you can think about very early signs, sort of middle signs and late signs about these processes, like sliding into depression, sliding up into hypomania. His very earliest warning sign of sliding into depression was what he called the can't be bothered. I'm not sure if every country has that phrase. It's a very common phrase in Australia, to can't be bothered. And he noticed it once when the penny dropped that this was an important feature of his slide into depression. Was a friend of his said, "Oh, let's go and watch your son play football," which is something that he would love to do normally. And he heard himself say, "Nah, I can't be bothered," which in Australia is kind of a phrase that you don't question. It just means, oh, well, I'm not going to do that. But he himself thought, oh, and we discussed it. And it actually turns out that that's a sort of a key indicator of that change in motivation that for him marked the very early signs of potentially a depressive episode. Another example at the other end, in terms of someone sliding up into hypomania, a client of mine realized that, in fact, she didn't notice changes in energy or mood or racing thoughts, which are the symptoms of mania and hypomania. What she noticed was a couple of more subtle things. She noticed that when she was becoming hypomanic, she would find herself looking in shop windows at clothes. And that was abnormal for her. She wasn't someone who was particularly interested in clothes. She wasn't someone who's particularly interested in shopping. But when she was starting to get hypomanic, all of a sudden she noticed things she wanted to buy. And this became a fairly reliable early sign. In that case, that particular person I was working with, one of her later signs of hypomania was that colours became much more vivid. So she knew she was moving further down that hypomanic pathway when she noticed colours becoming much more vivid. So these are the early warning signs that we need people to become expert on. And it's, as we say, it's different for everybody, but we can start by looking for things like changes in mood and sleep and activity, but often it's more personal things that people notice. And then, of course, the next thing is to have a plan. What do I do about that if that's actually occurring? Some people write that plan down, and if you're interested in learning this skill, Google WRAP, that's the Wellness Recovery Action Plan. That's just a simple but really well-known and well-accepted way of thinking through the development of a plan if things are going off the rails a bit. I encourage people who haven't seen the RAP plan to have a quick look at that. It's very straightforward, but we do find that there's something about actually writing down a plan that seems to be useful. There's a big difference between just thinking, oh, I'll do this, and actually committing to it. And committing to it would include writing it down, but committing to it might also include showing the plan to anyone else who's mentioned on the plan, right? So for example, I had a client once whose plan included, her plan around suicidal thinking included that she would contact her sister if she ever had significant suicidal thoughts. Now, that seemed like a great plan theoretically, but what we discovered was she went through an episode of suicidal thinking and she didn't call her sister. And I asked her, well, hang on, wasn't that your plan? What went on with that? And she discovered that, in fact, when she was in the mood where she was thinking about suicide, along with that mood came thoughts about, I don't want to disturb my sister. She's very busy with her job and the kids. Do you see what I mean? When you're making a plan, you've got to think through, when I'm in the mood where the plan might need to be activated, is that plan still feasible, right? So what we then did was, so once that my client had shared this with me, I said, okay, so your thoughts at the time were a barrier to you acting on your plan and with calling your sister, right? So how we addressed that in that particular case was my client agreed to go and have a chat to her sister and say, hey, this is your role in the plan. If I get suicidal thoughts, my plan is to call you to help talk me down, or to help me make good decisions about what to do next. Is that okay with you? And in this case, the sister said yes, absolutely. But I also got my client to ask a more concrete question of her sister, and that was, does that apply 24 hours a day? Because, of course, sometimes we get into bad states of mind at 2 o'clock in the morning, and I might be comfortable calling my sister at midday, but I may not be comfortable calling her at 2 o'clock in the morning. So what we wanted for my client was confirmation from her sister that this applied 24 hours a day. And in this case, the sister gave that confirmation. So you see what I mean? By planning, writing it down, imagining what it's going to be like if the plan needs to be activated, and in particular thinking through, what does this plan require of other people, and checking that they understand that what their role is. primarily so you yourself feel comfortable asking for that sort of assistance. That's how we really concretize a plan, and it becomes much more useful. And people do find once they've got that written plan in place, they do call on it a lot. It's one of the things we know from cognitive therapy. Cognitive therapy has taught us this, that in certain frames of mind, it's really hard to remember things that were common sense in other frames of mind, right? So, common sense. If I'm starting to feel depressed, I should call out, for support. Well, that makes perfect sense when I'm not depressed. But when I'm a bit depressed, I get other thoughts get activated about my worth, and I might get a bit hopeless. And so what would be common sense when I'm not depressed now doesn't seem sensible at all when I'm depressed. So what we do with these plans, it's kind of like writing a letter to your future self, a prompt to your future self who may not be thinking sensibly about this. And people do literally bring out the plan. They carry it with them. They have it somewhere readily accessible. And they think, oh, I'll just have a glance at that. Probably nothing I should do, but by seeing the plan written down, it prompts them of that different way of thinking about themselves, which they probably don't have spontaneous access to when they're getting depressed. Hope that makes sense. As part and connected to that is this third point. In terms of staying well, one of the things that people have always told us, and again, this is part of psychological treatment for bipolar disorder, is the importance of keeping an eye on, being mindful about the state of the disorder. So best practice is actually some sort of daily monitoring. Now, when I'm talking to clients about this, we have a discussion about it. Like, how is this going to be for you? Some people really like it. Some people say, I'm the sort of person who likes to keep records of things. Very happy jotting down each day, maybe a score from 0 to 10 on how well I am. Or some people might say, well, what I use is 2 scores, 0 to 10 on mania, 0 to 10 on depression. Some people say perfectly happy with that. Other people say, well, when I'm going okay with my bipolar disorder, I don't want to think about my bipolar disorder. So that's a barrier to that sort of monitoring. And so and that's fair enough, right? If a lot of people go through long periods where they're actually not dealing with active symptoms, especially if they've got the medication right. And they'll sometimes say to me, well, I don't want to be reminded on a daily basis of my bipolar disorder. And one of the things we sometimes do, at that point in the discussion, and it is a discussion, of course, because the person with bipolar disorder is the expert on their bipolar disorder. So as a professional, I'm not saying you must do this, because really it's the details that they carry. Oh, sorry, I don't know if I mentioned this. When we did that first study in Canada and collected this information from people, what we called it, when we published the scientific paper, we called it tips from the experts. And by the experts, we meant not us, of course, we meant the people with bipolar disorder. And that's very much how we think about this now. It's because bipolar disorder is an ongoing condition which differs so much across people. The person who has the diagnosis actually has specific insights about their self-management that there's no way that I could or any other clinician could necessarily guess. We might have general patterns, which is what I'm talking about today, things that tend to come up, but the details are, held by the individual. They are individual level details. Okay, sorry, back to the story. So we're talking about daily monitoring. Now, some people say, I don't want to be reminded of my bipolar disorder. And then sometimes what we do, and this is actually well worth thinking about, is, well, maybe we're not monitoring your bipolar disorder. Maybe we're monitoring your overall well-being. And in fact, for some people, that's what their daily monitoring turns out to be. For some people, for example, they're monitoring anxiety levels or relaxation levels or motivation generally, right? Depending on who you are, I think about this as like, you know, like the temperature gauge on your car that we just want to glance at regularly. Well, I remember when I had really bad cars when I was younger, that was a very serious thing that we needed to look at that every 20 minutes or so to make sure the engine wasn't going to blow up. Less so now, but monitoring the levels overall of your functioning, like how are you going today? How are you today? It's like a simple question, and it's not necessarily mania or depression that capture that. As I say, anxiety, optimism is one of the ones that some people have used that I've worked with. And it'd be really useful, I'd like you now to think about what might be the single indicator that you would be comfortable monitoring. Like, what's the question you would like to ask yourself on a daily basis, which is really, how are you going? But a bit more concrete than that. And just to say one thing about this, it does help many people if you put a number on it. There's something about quantifying, you know, putting a number on things that helps us stand back. So in an ideal world, we wouldn't necessarily want everyone with bipolar disorder to be asked the question, how are you going today? Because what that might lead to is sort of a, you know, a story about this and that, but not particularly useful in terms of this monitoring thing. So I would encourage people to actually try and score something. And I've mentioned a 0 to 10 scale before. Some people use 0 to 5, and just work out what the endpoints of the scale are. So for example, with if anxiety is the thing you're monitoring, some people might say 5 equals the most anxious I've ever been, and 0 means no anxiety. So that they're kind of useful numbers, right? But it's useful for you to think about, well, what score would I give myself today? This checking in takes virtually no time, but it is an opportunity to step back from what's going on in life and just check in with yourself, just check in with your well-being. And of course, these days, many people use apps to do that. At the end of the talk, I'm going to show you a link to a website which unpacks in more detail the sort of technologies that you can use to help you with this. And of course, just that last point that just caught my eye, some people really do learn over time that they have a relapse signature, a really quite clear pattern, which means they're on their way to an episode. Obviously, if you've only had 1 or 2 episodes, it's really hard to know that. So what we tend to do if you've only had a couple of episodes is to say, well, what sort of things do you see when you're getting stressed or starting not to cope well? So that could be unrelated to mania or depression. It could be times in your life where, as I say, things have gone off the rails a bit, you know, and looking back, you see, well, I didn't cope particularly well at that time. What's the pattern of that? Even if it's not to do with bipolar symptoms, that's where we'll start to look for, you know, triggers, what sort of thing might push you down this path, early signs, and things that might work. triggers, what might push you down that path, early signs, what are we on the lookout for, and what might work, things you might do should you start to see those early signs. The other element of this, oh, it's sunny in Australia now. So I can't quite see the screen unless I move forward. The other element that comes out really clearly in people's stories about coping well with bipolar disorder is this element that is the primary feature of, remember I said before, one of the psychological treatments is family-focused therapy. The primary focus of family-focused therapy is to improve knowledge and communication within families or between partners, to get that sort of social network thing working well with regards bipolar disorder. And the sorts of questions we want you to think about in this space in terms of your relationships, which are so important. There's very significant impact on managing and living well with bipolar disorder is maintenance of healthy and satisfying relationships. The question we really want people to think about is, well, who in your social network is useful for you around bipolar disorder? What makes someone a good support around your bipolar disorder? And what sort of features of a person make them not so good? And so, for example, it might be that, someone who is a great supporter and friend normally is actually not so good around mental health problems, right? And then that doesn't mean there's anything wrong with them, of course. It's not like a character flaw, but we may want to decide, well, that's not the person I'll choose to hang around with if I'm experiencing symptoms, or I might want to do some work on them. I might want to provide them with more education. I might want to, as it were, protect that relationship by putting in some work to give them more knowledge about bipolar disorder and the bipolar disorder that you yourself experience, right? But that would be a choice for you. You could say, well, that friend's great to go to the football with, or to enjoy watching Netflix with, but they're not so good when I'm starting to get hypomanic. In fact, they may be blind to that and therefore not very useful. And so I'll just not seek them out at those times. Or you might say, actually, they're such a good friend, I trust them. And just because they're not particularly knowledgeable about mental health, I can fix that by helping them understand it better. That would be a choice to make on a case-by-case basis. And then the other thing that we've learned is really important for in this sort of social space is the balance of being with people versus being solitary. And it's really useful for people with bipolar to think about how much time they need on their own as part of their well-being, and how that changes in different mood states. So, for example, everyone knows pretty much intuitively where they are on the introversion extroversion spectrum, right? Where extroverts are people who like more socializing, and introverts are people who don't. We encourage people to think about, well, when we say socializing, do we mean big groups, or do we mean a one-on-one chat with a friend? What sort of socializing suits you? But for people with bipolar disorder, we also encourage them to think about how your extroversion, if you like, varies depending on your mood. So when people are depressed, we know that one of the things that happens is they tend to withdraw socially. So remember I mentioned before the guy who gets the can't be bothered when he's depressed. So that's a very good example of just feeling like, well, there's nothing in that for me. I'm not going to go and do that. I can't imagine enjoying talking to those people. I can't imagine enjoying being in that space. And when we're depressed, that tendency to withdraw is probably something we want to fight against, right? You know, there's a general rule in the management of depression is if something seems like a bad idea, it probably isn't, right? So if going out to you know, accepting that invitation to go to a movie with a friend seems like a bad idea, it may not be when we're depressed, because depression tells us to withdraw, to back off. We don't have the energy. There's nothing in it for me. Our predictions about what's going to happen tend to be biased, don't they? And so just being conscious of how your tendencies around socialization change with mood. And of course, people are very familiar with what might happen with hypomania and particularly mania, that there might be an intense and potentially dangerous um, uh, uh, passion for connecting with new people, or going back through the address book and connecting with people you used to know. These are very common sort of drives that happen for people as they're sliding up with their bipolar disorder. And it's again useful to know yourself and think, well, this is starting to be a little bit of out of character. You know, when I'm well with my bipolar disorder, this, you know, this is not the sort of phone call I would normally make. So again, it's about that expertise about who you are and noticing how the different mood states might change your tendencies in relation to socializing, being expert on that social space. Cool. We need to move on. I'm conscious of the time. Because yeah, I want some time for questions at the end. If everyone who has a problem with their mood knows that maintaining good quality sleep is critical, and we know that there is a very strong relationship between sleep and mood. One of the things that we emphasize particularly, and this is something that the general public doesn't necessarily know, but we really need people with bipolar disorder to understand, and I hope you've heard this story before. One of the major determinants of how well we sleep is the strength of our daily routines. And what I mean by daily routines is how regular across days are the things you do every day. Like, for example, getting out of bed and going to bed and doing exercise and having the main meal of the day, leaving the house. They're things you do every day, right? How regular those things are. Like, do you get up at about the same time each day? That regularity of daily routines, what the scientific literature calls social rhythms, is really important for people with bipolar disorder in particular, but it's actually important for everybody as a determinant of sleep quality. So one of the first things we do with anyone who has a problem with sleep is we say, you need to pick a wake time and pretty much get up, wake up, set your alarm if necessary, at that time, 7 days a week, not 5. 7 days a week, not 5. And the window of you know, how tight that should be is about 45 minutes or an hour. So every day of the week, what time is sustainable for you in terms of getting up? And the reason this sort of regularity, and I mentioned before that I'm a drummer, the reason this regularity is so important is it helps the body clock, which is a part of everyone's biology. But people with bipolar disorder, their body clock tends to need a bit of external support, like a click track for a drummer. and our daily routines, the time we get up, the time we go to bed, the time we have lunch, provide that extra support for the body clock. I'm pointing there because that's where the body clock is located, which supports sleep. So that's just a general idea that we emphasize in, that's actually picked up a lot in interpersonal and social rhythm therapy for bipolar disorder, that notion of regularity of daily behaviors. And I must say, in my work with people with bipolar disorder over 20 years or so, this idea makes a lot of sense to people. They look back over their life and say, well, actually, I tend to be better when my lifestyle is stable. You know, when I was working, when I was at school, but when I went to uni, things went off a bit, or when I was traveling, things went off a bit because there was that lack of routine, right? It's interesting, isn't it? Because of that creativity thing we were talking about before, many people with bipolar disorder see themselves as not liking routine. But ironically, people with bipolar disorder actually benefit on average, obviously I'm talking averages here, from routine. And we've got two more quick points that we want to make. We haven't said anything about mindfulness yet, or meditation or yoga, but these things are central elements of staying well and with bipolar disorder. This is what we hear from the experts, people who say, yeah, look, I succeed in managing my bipolar disorder well. But there's also been a couple of very large international surveys of what people say are the most beneficial things for their bipolar disorder. And some sort of reflective or meditative practice, and that could be, you know, we get into these, I hope everyone on this call knows what this experience is like. It used to be called, you know, when I started in psychology, this used to be called active relaxation. That was the term we used for it. And the key point of that, of that being active, is that it's deliberate. You are deliberately putting yourself into a state of mind where you are relaxed, as it were, somewhat disconnected from, you know, the normal challenges of life. But these days, of course, we might use the words like meditation or mindfulness. Some people have a physical activity component to this, like through yoga or walking or playing music or listening to music or painting. But you know what those states are like, hopefully. You know what works for you in terms of something that you can fairly reliably. Of course, these things don't always work, do they? You know, I can't guarantee that doing some mindfulness or doing a yoga class is going to make me feel comfortable and relaxed, because maybe life is too stressful at that time. I can't guarantee it. It's not a silver bullet, but it's worth trying. And in fact, the key thing that people tell us is it's worth putting those sorts of activities in regularly, committing to them. So that's at least multiple times a week, if not every day. Now, just one little point on that. One of the things, you know, I just said you should potentially put in one of these activities every day. And I mentioned before the importance of getting up at about the same time each day. One of the things we've learned from those sorts of recommendations is it's very important not to be too rigid with yourself. So we need this flexibility around the commitment. So it doesn't, you know, sometimes we can get into sort of black and white thinking, you know, either I'm doing the right thing or I'm completely not doing the right thing. You know, the psychologist said I'm meant to get up at the same time each day. He said I'm meant to do yoga each day, but I'm not. But it's the best way to approach these sort of recommendations is to, yes, commit to trying to build these things into your life, but don't be too harsh on yourself when they don't actually happen. Everyone knows this. Behavior change is difficult. It's hard to get the average Australian to walk around the block for exercise, right? Even though we know that pretty much we'd solve our health crisis if we could do that. Yeah. Behavior change is difficult. So it's really important to be gentle on yourself while staying committed to some of these well-being strategies, which do involve some discipline. But when we use the word discipline, it often has a sort of harsh edge to it. And we want to take that harsh edge away. It's kind of an easy, flexible discipline that people tell us that's when they started to build lifelong habits, when they realized that you can be committed to a plan, but not be too judgmental of yourself if the plan doesn't work. And then I just want to check where we are. Yeah, good. Last point. We've spoken a bit about the importance of who you're going to be working with in managing your bipolar disorder. And it really is a team approach. And so it's really important that you think through, what do you need in a professional? We've just written the treatment guidelines for mood disorders in Australia, and this word collaborative comes up about 20 times in the treatment guidelines. That's what you should be aiming for in terms of your relationship with whoever the professionals are that you're working with. You should feel confident that they are interested in your opinion. You should be sufficiently expert in their language that you can understand what they're talking about. And there should be this sense of collaboration about shared efforts towards the best possible quality of life outcomes for you. And so we encourage people to think, what is the difference between a good relationship and a not so good one? What would you tell someone who's just been diagnosed with bipolar disorder in terms of seeking out a good professional? What's the gossip in your local networks about the importance of a relationship with a professional? What do other people tell you? How do you ensure, and this is a next step in this, how do you ensure that the various professionals that are involved in your care are relating to each other properly? This is something we're very conscious of in Australia, where people can see a psychiatrist and a psychologist, both funded through the government, at least partly funded through the government. But we need to check that that psychologist and psychiatrist are working together. So I just wanted to make that little observation that you're not just working with potentially with one individual and making sure you have a good relationship with them. It's also useful for you to think through actually who's in charge of the relationships between the different people who work with me. This is the sort of discussion, this sort of sophisticated discussion about the context of your treatment, what works, what doesn't, that people often benefit from being involved in, like support groups, for example, where this sort of very local knowledge about networks of professionals, etc. Often people in your local area will have that sort of rich, detailed local knowledge about those teams of care. Okay, I'm conscious of time. We've got about 10 minutes to go. I just want to show you that Crest BD site. So Crest BD is this international group of collaborating people, which involves consumers, clinicians, and researchers committed to improving quality of life for people with bipolar disorder. And a lot of what we've learned over the last 20 years or so is captured on the Bipolar Wellness Centre, which is an online site which speaks to most of the things I've spoken about today, but in much more detail. And it's also a very beautiful site with nice language and nice images and some nice videos of Victoria Maxwell, who's a mate of ours who lives with bipolar disorder, who's also a performer So yeah, it's just got a nice vibe to it. But the content is all evidence-based content around self-management. So I really encourage you to hop on there. And then I'm conscious that I haven't said anything today really from the viewpoint of caregivers of people with bipolar disorder. Bipolarcaregivers.org is the place to go for good quality information about looking after yourself while you're a carer of someone with bipolar disorder. I'm going to end it there, and we've got about 7 minutes to have a look at some questions. And as I said at the start, feel free to email me if we don't get to your question.
Thank you, Greg. It looks like we have time for a few questions, so I'll just start with some of them. And of course, if you see any you'd like to address specifically, you can just interject. So for the first question, somebody asked, what would you say is the #1 way to come to acceptance with a bipolar diagnosis?
Yeah, that's a really good question. My first thought is it differs for different people. My second thought is one of the things that I've seen with people coming to accept the condition is really to try and think about it in a destigmatized way. So that's why I said before, kind of like diabetes. That's how I think about bipolar disorder. It's a challenge in life that doesn't go away, which involves active work on the part of the person with the condition. It involves, you know, frustrating and difficult and time-consuming activities to do with the health system, you know, that just like diabetes does, or problems with your heart, or many people have cancer as life goes on, and these other chronic conditions. And if you think about bipolar disorder that way, it's kind of just like the particular challenge that you've been thrown, and being mindful that just about every adult has something like this. I can't remember the statistics now, but as life goes on, the proportion of people who carry a chronic condition that we have no cure for becomes, really enormous in the general population. This is what life is like. So you can see how I think it's really important that mental health conditions get seen in the same way as other things. And I've seen in the people I've worked with bipolar disorder that they are starting to accept their bipolar disorder when they start to see it in that way. They've kind of taken the stigma out of the diagnosis. They've taken the emotion out of it. I'll just say one more thing. Sometimes, because bipolar disorder can run in families, sometimes people have really bad associations with the term bipolar disorder. Maybe their auntie or their grandpa had very, very severe bipolar disorder, and things did not go at all well for them. Very important to realize that just because that was the version of bipolar disorder that someone in your family had, that doesn't mean you're going to have that version of bipolar disorder. So it's not necessarily as catastrophic as perhaps you perceived it to be when you were looking around your family. So just be careful that you're not bringing historical understandings of bipolar to bear on your particular case. And of course, treatments have improved enormously. Self-management, this whole thing we were talking about today, that didn't exist 15 years ago. Patient empowerment didn't exist 15 years ago. A lot of the way we're talking about bipolar disorder just didn't exist. So yeah, just be careful about carrying stigma, internalized stigma from your own experience. They're the first thoughts I have on that question.
Thank you for that explanation. So we had quite a few questions coming in about medication and bipolar, and a lot of people asked, is it possible to ever manage bipolar without medication, instead through diet, supplements, lifestyle changes, or is medication the only option?
Yeah, really good question, and we always get asked this. Firstly, I'm not a prescriber, I'm a psychologist, so, I would prefer that to be asked of a psychiatrist. But I am asked this question a lot, and the short answer is we don't have any strong evidence that most people with bipolar disorder can manage their condition without medication. That was a badly structured sentence, wasn't it? But there have been very few studies, there have been no studies done to help us understand how people could possibly come off medication or just manage their bipolar disorder with lifestyle and psychological changes. Now, so we're just in a data-free zone, and we do know that people who spontaneously come off medication have very bad outcomes. That is really not a good thing to do. There's something about how medication works that if you just take yourself off medication, that really seriously does not work, and no one should do that. We also know that a lot of people want to talk to their prescriber about slowly coming off medication, and there are some hints that sort of anecdotal evidence from clinicians about what might be useful if someone wants to try that. But it is very much try. As I say, that we just haven't looked at, what sort of person, how would we know someone is one of the people who potentially could manage their bipolar disorder without medication? We don't know what that is, but there are some anecdotal hints, and not surprisingly, one of the key things that clinicians say, prescribers say, is very, very slow titration of medication, which means, decreasing across time, and very, very close monitoring of mood, sleep, activity as we're titrating. And we're talking across months that this titration might happen, but under the very close observation of the prescriber. As I say, that's anecdotal. There's not strong evidence that that works. We don't know for what proportion of people that titration down is going to leave them safe and well with their bipolar disorder, and we don't know who those people might be. So I'm sorry, I think it's a significant gap in the literature that we really don't know, but we do know that best practice treatment is the combination of medication and psychological therapy, and we do know that people who come off medication themselves have very bad outcomes. So it's a complicated area, and I suppose my recommendation is, if this is a question for you, you should be speaking to your prescriber about it. It'll be a case-by-case thing, and they'll be acting in the context of very little evidence.
Thank you for that explanation. That looks like all the time we have for questions today, but I'd like to remind you all, as Greg previously mentioned, if we didn't get to your question, you can email it to him directly and he'll try to answer it. And then also, if you need help finding any resources or anything that we can help you with, our email is on our website. I'd also like to remind you all that if you would like to rewatch this webinar, it will be available on our website tomorrow. And a big thank you to Greg for your wonderful presentation. We really appreciate it.